Neurology quiz number 110. Describe the etiology, clinical features, investigation and treatment of autoimmune encephalitis. Part 2 of 2. Anti-Iglon 5 encephalitis. The Iglon proteins are a family of neural cell adhesion molecules. Anti-Iglon 5 disease is associated with antibody to Iglon 5. The disease has association with HLA-DRB1 and HLA-DBQ1. The condition can also occur as a paraneoplastic syndrome. The usual age of onset is 45 to 75 years. 4 major clinical presentations occur: a sleep disorder with parasomnia, both REM and non-REM, and sleep breathing difficulty, a bulbar syndrome with dysphagia, sialorrhea, stridor, and acute respiratory insufficiency, a progressive supranuclear palsy-like syndrome with vertical and horizontal gaze palsies and gait difficulty, and cognitive decline with chorea. Other clinical features include dysautonomia and myoclonus. Pathological features include neuronal loss and p-tau protein accumulation in the hypothalamus and brainstem tegmentum. The antibody is found in serum and CSF in more than 90% of the cases. Some series have reported high mortality, as much as 34%. Response to immunotherapy has been poor, but there are reports that combination immunotherapy may be more effective. Anti-DPPX encephalitis. It is an autoimmune condition associated with antibodies against DPPX, a regulatory protein of potassium channels. In some patients, it may occur as a paraneoplastic syndrome associated with systemic lymphoma. Median age of onset is in the 50s. The course is subacute and patients have a prodromal phase of significant weight loss and diarrhea. Subsequent neurological symptoms include memory loss, mood and personality changes, CNS hyperexcitability including hyperexplexia, myoclonus, tremor, seizures, and muscle rigidity. MRI changes are nonspecific. CSF may show pleocytosis and intrathecal IgG synthesis. The anti-DPPX antibody is detected in both serum and CSF. Good response to immunotherapy has been reported. Treatment includes IV solimedrol, IVIG, and plasma exchange. Anti-glycine receptor encephalitis. PERM, or progressive encephalomyelitis with rigidity and myoclonus, is a neurological disorder associated with glycine receptor antibodies. The condition affects men and women equally and can occur in children and adults. Clinical features include muscle rigidity, muscle spasms, myoclonus, and hyperexplexia, as well as evidence of brainstem dysfunction, long track signs, and dysautonomia. Rigidity and spasms are most common in the distal limbs, but can involve the trunk and proximal muscles. Brainstem signs include ophthalmoparesis, nystagmus, opsoclonus, dysphagia, dysarthria, and deafness, and these may precede muscle rigidity. Long track signs include pyramidal signs as well as cerebellar ataxia. Autonomic instability and dysfunction is common. Less common features include neuropathic pain as well as seizures and cognitive disturbances. Antibodies are detected both in serum and CSF. Less than 20% of patients have underlying malignancy, most commonly thymoma and lymphoma, as well as cancer, breast and lung. Treatment can be symptomatic in the form of benzodiazepines or baclofen for rigidity and spasms, clonazepam for hyperexplexia, and clonazepam and levetiracetam and valproate for myoclonus and seizures. Immunomodulatory treatment. This is usually started with IV solimedrol followed by oral prednisone. Treatment with IVIG and or plasma exchange if no response to steroids. Long-term immunosuppression with rituximab, azathioprine, mycophenolate, or cyclosporin in relapsing or resistant cases. This is a video of a patient with PERM. It shows spasticity of the legs with plantar flexion of the feet and intermittent myoclonic jerking. Anti-GABA B and anti-AMPA encephalitis. These antibodies are typically associated with limbic encephalitis. They are associated with small cell lung cancer and thymoma. Clinical features include an acute to subacute onset of amnesia, seizures, and behavioral changes. MRI shows T2 flare, hyperintensity, and swelling in the mesial temporal lobes. GABA B receptor antibodies can also be a cause of new onset refractory status epilepticus and a rapidly progressive dementia resembling CJD. GABA-A encephalitis. GABA-A antibodies are associated with diffuse encephalitis. Seizures are prominent and status epilepticus is frequently seen. The MRI shows flared hyperintensity in 2 or more brain regions in more than 75% of the cases. This is an MRI from a patient with limbic encephalitis. This is a flared image showing hyperintensity in bilateral mesial temporal lobes. Encephalitis due to antibodies directed against intracellular or intraneuronal antigen includes GFAP antibody disease, ANA1 or anti-Hu antibody, CRIMP5 or anti-CV2 antibody. GFAP antibody disease. This is an autoimmune meningoencephalitis related to GFAP antibodies. It usually occurs in adults after age 40. Preceding flu-like symptoms like fever, cough, and rhinorrhea occur in up to 2/3 of patients. Subsequently, patients develop headache, neck stiffness, photophobia, and encephalopathy with seizures, cognitive and psychiatric disturbances. Spinal cord involvement can occur, but myelopathic symptoms are mild. Bilateral disc edema is noted, but CSF opening pressure is often normal. Other neurological features include tremor, myoclonus, chorea, ataxia, dysautonomia, and neuropathy. CSF shows lymphocytic pleocytosis, high protein, and OCBs may be positive. GFAP antibody is positive. It is best tested for in the CSF, as serum positivity alone carries risk of false positives, and underlying neoplasm, especially ovarian teratoma, has been reported in some series. Coexistent NMDAR and NMO antibodies may be detected. Brain MRI may show leptomeningeal enhancement and a characteristic radial perivascular enhancement perpendicular to the ventricles. T2 hyperintensities may be seen in subcortical white matter, brainstem, and cerebellum. In the spinal cord, a longitudinally extensive faint T2 hyperintensity may be seen. The condition is responsive to steroids, and recommended management is IV solimedrol followed by high-dose oral steroids for 3 to 6 months and then a slow taper. This is a brain MRI with contrast showing the characteristic linear perivascular radial enhancement pattern as shown by the arrowheads in GFAP antibody disease. ANA1 or anti-Hu and CRIMP5 antibodies. These antibodies are associated with multifocal CNS involvement, manifesting with cognitive dysfunction, movement disorders, and myelopathy. ANA1 antibody is also associated with typical limbic encephalitis, presenting as memory deficits, seizures, and psychiatric dysfunction, with high-intensity flare lesions on MRI. Underlying cancers include small cell lung cancer, breast cancer, and adenocarcinoma. Seronegative autoimmune encephalitis. Some patients have a clinical syndrome compatible with autoimmune encephalitis without detectable antibody. In such cases, it may be justifiable to begin early immunotherapy, given that autoimmune encephalitis is treatable and early treatment improves outcome. However, this is a diagnosis of exclusion, and testing to reevaluate for possible alternative diagnoses should be continued. According to some estimates, such patients may constitute up to 30% of cases and have some of the worst clinical outcomes. Antibody testing. It is recommended that both CSF and serum be tested for antibodies in all cases. Serum testing should be done before plasma exchange is instituted. In general, CSF has higher specificity with a lower rate of false positive tests. However, LGI1 antibodies may not be detected in 50% of CSF samples, while NMDAR may be absent in the serum in 20% of patients. Serum antibody testing is associated with higher false positive results in MOG and Caspar-2 antibody disease. Interpretation of antibody testing also requires consideration of the immunoassay methods. For detection of antibodies against cell surface antigens, ELISA testing does not yield useful results. Other methods, such as the use of live or fixed cell-based assays, provide more accurate results. Treatment. Immunotherapy is the mainstay of treatment, although supportive care for other manifestations such as seizures, psychiatric manifestations, autonomic dysfunction, etc. is also required. Prompt immunotherapy has been shown to improve outcome, and with the appropriate clinical features is often started empirically without waiting for positive test results. First-line immunotherapy. The most common initial treatment is high-dose steroids given IV or PO. A dramatic response can be seen in conditions like LGI1 encephalitis. IVIG and plasma exchange are also considered first line and can be administered simultaneously or sequentially with steroids. In NMDAR antibody encephalitis, this combination therapy has been reported to restore 50% of patients to a good functional outcome if given within the first 30 days of symptom onset. Removal of associated tumors such as teratoma and NMDAR antibody encephalitis is also considered as part of immunotherapy, as it helps to remove the generator of the immune-mediated process. Second-line immunotherapy. These agents include rituximab and cyclophosphamide. These can be effective in patients with NMDAR antibody encephalitis who are resistant to first-line treatment. Other indications are patients with Eglon-5 antibody encephalitis. Third-line agents. These can include medications such as tocilizumab or bortezomib. They are usually considered in patients with refractory autoimmune encephalitis, including the seronegative type. Relapses are common in some types, and a relapse rate of 15 to 40% is reported in patients with LGI1, NMDAR, CASPA2, and GABA-B encephalitis. Patients with antibodies targeting intracellular antigens have worse outcomes with limited response to treatment, and the deficits are not reversible.